Welcome back to the deep dive. Today, our focus is razor sharp and absolutely critical for your exams. We are doing an exhaustive postgraduate level deep dive into Remimazolam. This is a drug that has, well, it's rapidly transformed how we approach intravenous anesthesia and procedural sedation.
It really has.
And we're structuring this analysis not just to teach you the facts, but to really prepare you for those inevitable long answer questions and, the challenging Viva scenarios that are going to come up around this new agent.
That's the critical distinction, isn't it? Remimazolam, or RMZ as we'll probably call it, is not just another benzodiazepine.
Right.
It's really a successful pharmaceutical effort to fix the central clinical flaws of its predecessors. For your MD exams, understanding the why, the underlying chemical and pharmacokinetic reasons is so much more valuable than just reciting a dose.
Exactly.
Our mission today is to give you that conceptual framework so you can defend its use against the established agents like Midazolam and Propofol.
Okay, so let's set that foundation. How do we formally define and classify Remimazolam?
Formally, Remimazolam is classified as a novel ultra-short-acting benzodiazepine derivative. It shares a fundamental structure and mechanism of action with traditional BZDs like midazolam, lorazepam.
The ones we know well.
The ones you know very well. They all target the GABA-A receptor. But that word novel is crucial here. It signals a specific intentional chemical change that was designed to give it entirely new pharmacokinetic properties.
So why is it specifically called ultra-short-acting? I mean, we already think of midazolam as being a relatively short-acting BZD. Where's the specific difference?
It all comes down to its metabolic pathway. The ultra-short action is all because of a unique structural change. The addition of a carboxylic ester side group.
Wow, okay.
That's the engineered weak spot, if you like. This ester linkage allows for rapid, nonspecific, and incredibly efficient metabolism by tissue esterases that are just, everywhere in the body.
So it's not relying on the liver.
Exactly. It's not relying on those variable, capacity-limited hepatic pathways that classic BZDs use. And that speed is what truly, fundamentally separates it from midazolam.
So if the onset and offset are that rapid and predictable, what's its relevance in modern anesthesia practice right now? What problem is it solving in the operating room?
It's solving a couple of big ones. First, its predictable and rapid on-off profile makes it just perfect for procedures that need quick titration and a short effect. Think high-volume endoscopy lists or, rapid patient turnover in daycare surgery.
Right.
And second, it solves that notorious problem of prolonged sedation you can see with the older BZDs, specifically the unpredictable accumulation of active metabolites, which is a major, major issue when you use midazolam in patients with renal impairment.
Okay, so when examiners approach a newer agent like this in a Viva or a written paper, what's the best strategy for a candidate to take?
The examiners want to see that you understand the innovation. That's the key. They test new drugs almost exclusively by demanding detailed comparisons to the established agents.
Okay, so a compare and contrast approach.
Yes, and you have to focus on the unique selling proposition. For RMZ, that means framing your answer around that contrast. You say, midazolam relies on hepatic CYP450 metabolism, and it generates an active metabolite, which leads to a context-dependent recovery.
Right.
Remimazolam, on the other hand, relies on organ-independent tissue esterases. It generates an inactive metabolite, and therefore it has a context-insensitive half-time. If you can articulate that PK difference, you're showing a level of conceptual mastery that goes way beyond just memorizing facts.
That makes perfect sense. Let's move to those technical underpinnings then, the chemical and pharmaceutical profile. We keep stressing this unique ester bond, but let's give the chemical definition you'd need for a thorough exam answer.
Chemically, RMZ is an ester-based benzodiazepine. And to be more specific, it's an Imidazobenzodiazepine derivative, which is the exact same core structural class as midazolam. The critical feature, as we said, is that carboxylic ester side group. That's the metabolically weak part. For reference, the molecular weight as the bisylate salt is 597.5 daltons, and its pKi is 5.3.
That pKi 5.3 is interesting. When we talk about BZDs, the relationship to midazolam structure is so important, especially when it comes to things like solubility and injection pain. Can you elaborate on that structural link?
Sure. RMZ was really designed by strategically tweaking midazolam. Midazolam itself is unique among the classic BZDs because it has an imidazole ring.
Right, which makes it water-soluble in the vial.
Exactly. That ring allows for a pH-dependent change. At the low acidic pH of the formulation, around 3.5, it's water-soluble, so you don't need irritating solvents like propylene glycol. But when you inject it into the body at a physiological pH of 7.4, the ring closes, the drug becomes highly lipid-soluble, and it zips across into the CNS.
And Remimazolam keeps that feature.
It does. It retains that desirable structural class, the Imidazobenzodiazepine structure, which gives it good formulation properties and rapid entry into the brain. But then the designers added that crucial ester group specifically to create a metabolic escape hatch. So they kept the good part, the pH-dependent solubility, while building in a high-speed clearance system. It's really quite elegant.
Speaking of administration, then, how is it formulated, and does that mean there's less venous irritation?
It's administered intravenously, IV, and while its water solubility is inherently low at a neutral pH, it's highly soluble at an acidic pH. This confirms that, just like midazolam, it's formulated in an acidic, water-soluble way.
So no phlebitis issues like with diazepam.
Exactly. It avoids all those venous irritation and phlebitis problems you see with the older BZDs that are delivered in those irritating organic vehicles.
That brings up a subtle but really important point about stability and storage. We're dealing with an ester, which we know can be prone to breaking down in water, spontaneous hydrolysis. So how is the drug stable enough to just sit on a shelf?
That is an excellent advanced point, and it separates a true conceptual understanding from just reciting facts. While the ester structure is designed for rapid metabolism in vivo by enzymes, the pharmaceutical engineers had to design the drug and its formulation, the pH, the buffers, to stabilize that ester bond in vitro.
I see.
The very fact that RMZ has a usable shelf life and is on the market confirms it's a successful chemical design. It's sufficiently resistant to spontaneous, non-enzymatic breakdown, unlike, say, succinylcholine, which, has to be refrigerated because it degrades so quickly. It's a real testament to the sophistication of modern soft drug design.
Okay, so we understand the structure. Let's move to how it actually works. Mechanism of action is absolutely non-negotiable for a pharmacology exam. Let's detail its action on the GABA-A receptor.
Okay. RMZ produces its entire hypnotic, sedative, and amnestic effect by acting as a high-affinity ligand for the GABA-A receptor. And as you know, GABA is the main inhibitory neurotransmitter in the CNS. The fundamental action of all BZDs is to bind to this receptor complex, which in turn facilitates the action of the GABA that's already there.
Examiners always want specifics here. How does a BZD like Remimazolam differ in its interaction with the GABA-A receptor compared to other depressants we use like Propofol or, say, barbiturates?
This is a crucial distinction. RMZ is what we call a positive allosteric modulator. It binds to the benzodiazepine site, which is a different spot from where GABA itself binds.
Okay.
When RMZ binds, it changes the receptor shape so that when GABA does bind, the chloride ion channel opens more frequently. The membrane hyperpolarizes, making the neuron less excitable. This mechanism is key because it requires GABA to be present. It has a sort of self-limiting effect.
And how does that contrast with barbiturates?
Right, so barbiturates at low doses also enhance GABA's action, but they primarily increase the duration of the chloride channel opening, not the frequency.
The duration, okay.
And critically, at higher clinical doses, barbiturates become direct GABA agonists. They can open the chloride channel even if there's no GABA around. This GABA mimetic action is why barbiturates have a much steeper dose-response curve and a much higher risk of profound, irreversible depression and death compared to BZDs, which have a ceiling effect because they only facilitate GABA.
And where exactly is this benzodiazepine site on the receptor? And which subunits are mediating the effects that we care about clinically?
The GABA-A receptor is a pentameric structure made of 5 subunits. The BZD recognition site is located specifically at the interface between the alpha and gamma subunits. And while there are many different types, the clinical effects we want, sedation, hypnosis, anterograde amnesia, are predominantly mediated through binding to receptors that contain the alpha-1 subunit. Knowing the alpha and gamma interface is a detail that shows real mastery.
So we get the entire BZD spectrum of effects, sedative, anxiolytic, amnestic.
Yes, all of them. Hypnosis, anxiolysis, profound anterograde amnesia, which is a highly valued effect in procedural sedation, anticonvulsant activity, and central muscle relaxation. The unique feature RMZ brings to the standard BZD profile is the clinical speed. You get a rapid onset of these effects, but it's followed by a significantly faster and, cleaner recovery of neuropsychiatric function compared to midazolam.
Now, for the most vital functional limitation, this is one that requires caution when you're administering it.
Yeah.
The lack of analgesic action.
This is a critical point, and it's one examiners will absolutely use to trip up candidates. Systemic BZDs, including Remimazolam, are purely CNS depressants and hypnotics. They do not provide any useful analgesia.
So for a painful procedure.
For any painful procedure, an endoscopy, putting in a regional block, surgical induction, you must give a concurrent opioid, fentanyl, remifentanil, something. And that necessity immediately introduces the risk of additive CNS and respiratory depression, which means you have to be so careful with titrating both agents at the same time.
Okay, that makes sense. So if the mechanism of action is pretty standard for a BZD, the pharmacokinetics are where it's absolutely revolutionary. This is the drug's signature, and we should spend some serious time here. Let's start with the rapid onset of action.
The rapid onset is down to two factors. First, its high lipid solubility. Its log P is 3.724, which is almost identical to Midazolam's. This lets it cross the blood-brain barrier very quickly into the vessel-rich tissues like the brain.
And a second factor.
Its high unionized fraction at physiological pH. Both of those features just ensure it gets to the effect site and reaches equilibrium very, very quickly.
So the fast onset is great, but the fast offset is the real groundbreaking clinical advantage. Can you detail the metabolism by tissue esterases? Because this is the single most important point about this drug.
Absolutely. The defining feature of Remimazolam is its reliance on nonspecific plasma and tissue esterases for clearance. The main enzyme responsible is carboxylesterase 1, or CES1, and this enzyme is everywhere: liver, lungs, plasma, other tissues.
So it's ubiquitous.
It is, and when CES1 encounters that ester bond on the RMZ molecule, it just rapidly hydrolyzes it, breaks it apart.
And that's the organ-independent part.
That's the revolutionary part for a BZD, yes. It confers organ-independent metabolism. This means the clearance rate isn't dependent on hepatic blood flow or the capacity of liver enzymes like CYP450 or even renal excretion capacity. It is a highly efficient, high-capacity, and constant elimination process no matter what the patient's major organ function is like. It's the core reason we call it a soft drug, borrowing that concept from remifentanil.
That immediate breakdown must mean we avoid the problems we see with midazolam's metabolites. What are the key details on the formation of inactive metabolites?
This is the perfect contrast to midazolam. The hydrolysis of RMZ converts it into an inactive carboxylic acid derivative, which is called CNS7054. And critically, CNS7054 has negligible hypnotic activity. We're talking less than 1/1000th the potency of the parent drug.
And it's cleared quickly.
Yes, it's rapidly excreted by the kidneys. So since the parent drug is cleared so fast and the metabolite is functionally inert, there is just no risk of any residual or prolonged clinical effect.
Let's contrast that one more time with midazolam and diazepam, because this point is vital for patient selection in the exam.
Right. Midazolam, as we said, is metabolized in the liver by CYP3A4, producing 1-hydroxymidazolam. This metabolite is pharmacologically active. It's got about 50% of the hypnotic activity of the parent drug.
And in renal failure?
In patients with renal failure, this active metabolite accumulates, and it can cause significant, unpredictable, sometimes very prolonged sedation long after the procedure is over. Diazepam is even worse, with multiple active metabolites that have extremely long half-lives. RMZ's clean, inactive metabolite profile makes it a vastly superior choice in any patient with impaired organ function.
This high-speed constant clearance must translate directly into a phenomenal context-sensitive half-time, or CSHT. Why is CSHT such a critical metric, and what does RMZ's profile look like?
The CSHT is the single best predictor of how long it takes a patient to recover after you stop a continuous infusion. It's the time needed for the plasma concentration to drop by half. For traditional IV agents, the CSHT gets longer and longer the longer you run the infusion.
Because it's accumulating in tissues.
Exactly. It's saturating peripheral compartments and has to rely on slower elimination pathways. But because RMZ's elimination is constant, rapid, and independent of major organ capacity, with a very high clearance rate of about 70 LEOG, its ultra-short duration results in a CSHT that is effectively independent of how long it's been infused.
Wow.
We're talking an elimination half-life of roughly 0.4 hours or 24 minutes. This means whether you infuse RMZ for 5 minutes or 5 hours, the time it takes for the patient to wake up stays predictable and short. That context insensitivity is probably its greatest clinical advantage for long cases where you might need a rapid neurologic assessment.
So this all leads to an extremely predictable recovery profile. For the clinician, what does that predictability guarantee?
It guarantees titratability and certainty. Because of its clean first-order pharmacokinetics and that organ-independent metabolism, the level and duration of sedation are precisely dose-dependent. Stopping the infusion provides an immediate and guaranteed termination of effect, and that is absolutely critical for daycare settings. It reduces the time patients spend in recovery and improves overall operating room efficiency. You just can't get that level of certainty with Midazolam or even Propofol after a long infusion.
Okay, let's transition now into pharmacodynamics, what the drug actually does to the body's organ systems, starting with the cardiovascular effects. This is a massive point of comparison against Propofol.
It is. RMZ retains the hemodynamic profile that's characteristic of the BZD class, which is to say relatively stable hemodynamics. Clinical studies confirm there are no significant clinically relevant effects on heart rate or the ECG. Its effect on blood pressure is similar to Midazolam, so it typically causes only a modest transient drop. This is largely because BZDs tend to preserve homeostatic reflex mechanisms better than other agents.
Can you delve a bit deeper into that Propofol contrast? If you are inducing a high-risk cardiac patient, how does Remimazolam protect their hemodynamics better than Propofol does?
Propofol causes significant dose-dependent hypotension. It does this mainly through massive peripheral vasodilation, which causes a severe drop in systemic vascular resistance, and it often inhibits the bear reflex as well.
Right.
RNZ, on the other hand, causes less profound hypotension and, as a result, requires fewer vasopressors compared with Propofol. This makes RMZ an inherently safer choice for patients who are volume depleted, have poor left ventricular function, or really rely on maintaining their SVR to ensure they have adequate coronary perfusion pressure. This superior hemodynamic stability is a top-tier exam point.
Moving on to respiratory effects. Can RMZ cause apnea or dangerous respiratory depression?
Yes, absolutely. Like all potent sedative hypnotic agents, respiratory depression is a dose-related adverse effect. BZDs generally flatten the ventilatory response curve to carbon dioxide.
But how does it compare?
When you look at the head-to-head clinical trials, RMZ showed similar or even slightly fewer events of desaturation or respiratory depression compared with Midazolam, as long as it's titrated carefully. The risk is manageable, but the critical warning remains. If you co-administer it with opioids, you get synergistic respiratory depression, and that demands meticulous monitoring.
So summarizing the central nervous system effects, it delivers the standard BZD package, but the real clinical difference is in the recovery.
That's right. Rapid induction, rapid onset of amnesia, anxiolysis, sedation. But the key functional advantage is that faster recovery of neuropsychiatric function compared to Midazolam that facilitates earlier cognitive testing and ultimately earlier discharge.
So if we put this all together, RMZ seems to offer a unique profile when we compare it dynamically with Propofol and Midazolam. Where does it sit clinically?
It occupies a true pharmacological sweet spot. It provides the rapid, context-insensitive kinetics and high clearance that we traditionally associate with Propofol. That's the speed component. Yet it retains the superior hemodynamic and respiratory stability that's characteristic of BZDBs. That's the safety component. It's really the best of both worlds, and it doesn't have the accumulation risk that's inherent to Midazolam. This balance makes it highly competitive, especially in our more vulnerable patients.
Let's translate this science into clinical uses. For the exam, we need to know where it is approved and where it provides a distinct clinical advantage, starting with procedural sedation.
Procedural sedation is its primary approved indication. In the U.S., it's specifically approved for procedures lasting 30 minutes or less. The EU approval is a bit less duration-specific. It has shown excellent results in procedures like colonoscopy, upper GI endoscopy, and bronchoscopy.
And what does the data show about its efficacy in those procedures compared to the older standards?
The clinical data shows that RMZ achieves a sedative success rate that is statistically comparable to Propofol, but significantly greater than Midazolam.
And why is that?
It's likely due to the ease of titration. Its rapid kinetics allow the clinician to quickly adjust the dose to get to the target depth sedation without being afraid of a prolonged recovery.
And beyond sedation.
It's also licensed for the induction and maintenance of general anesthesia. It can serve as a highly effective hypnotic component, especially in balanced anesthetic techniques.
Let's talk about those critical special populations. How does Remimazolam change our strategy when we're treating elderly patients?
It's an important point. While the underlying pharmacokinetics, the clearance by esterases, remain largely unchanged by age, the frail elderly often exhibit increased pharmacodynamic sensitivity.
Meaning they're just more sensitive to the drug's effects.
Exactly, more sensitive at the receptor level. So for frail elderly patients or those with a high ASA physical status, like ASA 3 or 4, the guidelines recommend considering lower initial boluses and reduced maintenance infusion doses to mitigate the risk of excessive sedation or hemodynamic changes.
And the highest yield area here is its use in hemodynamically unstable patients and those with end-stage organ failure. This is where the drug becomes a real strategic advantage.
Absolutely. Because it causes significantly less of a blood pressure drop than Propofol, RMZ is exceptionally suitable for high-risk patients. ASA 3 and 4, particularly those with severe cardiac dysfunction or baseline hypotension, where Propofol's vasodilatory effects could be, well, catastrophic.
The PK profile is key for these patients, too.
It's the clinical brilliance for these patients. Its organ-independent metabolism means that clearance stays efficient even in severe end-stage renal failure, where midazolam would lead to that metabolite accumulation and potentially a prolonged postoperative coma. Therefore, RMZ is really an optimal choice for high-risk patients with renal failure.
Its kinetics also make it a perfect agent for daycare procedures.
The ability to guarantee a rapid, predictable, and clean recovery is just paramount in the ambulatory setting. The ultra-short action facilitates faster patient recovery of mobility and cognitive function, which allows for significantly faster discharge readiness and improves the overall patient throughput. That's a huge metric for daycare centers.
What about its theoretical use for ICU sedation? We often use remifentanil for its rapid off switch to facilitate neurological assessment. Could RMZ serve a similar role?
Widespread adoption in the ICU is still evolving, but theoretically, it's perfectly suited. RMZ has the exact same advantages as remifentanil: organ-independent metabolism and context insensitivity.
So you can wake them up quickly.
Exactly. For continuous sedation in the ICU, RMZ allows for an immediate stop to the infusion and a rapid, predictable wake-up. This enables a quick neurological assessment checking for delirium or assessing response to pain without the delay and unpredictability that you get with long midazolam or lorazepam infusions. This potential for rapid titration and assessment is a huge theoretical advantage over traditional BZD infusions in critical care.
Okay, let's solidify the required knowledge on dosage and administration. What are the key numbers to remember for the exam?
For procedural sedation, the recommended initial bolus dose is typically 2.5 to 5.0 milligrams intravenously. If you're using it as a sole agent without supplemental opioids, particularly in places like the EU, the initial bolus can be increased up to 7 milligrams.
And for top-ups?
Redosing or supplemental boluses during the procedure are usually managed with smaller increments of 1.25 to 2.5 milligram as needed. It allows for very light titration.
What about for maintenance of general anesthesia?
The consensus recommended maintenance dose is around 1 milligram per kilogram per hour. However, clinical trials have used a wider range for maintenance, finding regimens of both 6 or even 12 milligram kilo to be equally effective and safe, especially when balanced with other agents. This flexibility really reflects its high clearance rate.
Now, let's reinforce those critical dose adjustments in special populations. Where do we need to be cautious?
Focus on the high-yield contrasts. First, renal impairment. Because of the organ-independent metabolism and inactive metabolite, studies show no significant change in pharmacokinetics in end-stage renal failure. That means no routine dose adjustment is required. This is a crucial distinction from midazolam.
Okay.
Second, elderly or frail patients. Due to that increased pharmacodynamic sensitivity, you should always consider lower infusion doses and boluses, especially in ASA class 3 or higher.
And what about the liver?
Third, hepatic impairment.
This is the nuanced caveat.
While the primary clearance is organ-independent, you still need to be cautious in cases of severe hepatic impairment. Studies show the sedative effects can be increased, which means a potential dose reduction is necessary. This suggests that while CES1 is everywhere, the overall processing capacity or maybe receptor sensitivity might be altered in the most severe cases of liver disease.
Let's summarize the superiority of Remimazolam. This section is where we can consolidate the bullet points you'd need for the advantages part of a long-form essay.
Right. Start with the kinetics. The rapid onset and offset is paramount. The elimination half-life of around 0.4 hours ensures quick titration and termination of effect. This minimizes recovery room time and vastly improves predictability.
Next, the clinical stability argument.
Hemodynamic stability. This is its safety edge over Propofol. It causes less hypotension, requires fewer vasopressors, making it ideal for the hemodynamically fragile or high-risk patient population. It maintains the desirable stability of midazolam without the associated PK risks.
And the PK payoff predictability.
Predictable recovery. This is the core distinction from traditional BZDs. Because the clearance is so high and elimination follows first-order kinetics via esterases, the context-sensitive half-time is reliably independent of the infusion's duration. You can infuse it for hours and still guarantee a rapid recovery, which is just impossible with midazolam or long-term propofol.
And finally, the BZD safety net.
The availability of a specific antagonist, flumazenil. This provides an instant reversal option, an unparalleled safety margin that is completely absent for propofol. And because RMZ is so short-acting and produces inactive metabolites, the risk of resedation after you give flumazenil is dramatically minimized. That enhances the overall safety profile even more.
A complete exam answer has to be balanced. Let's discuss the potential downsides and necessary precautions, the adverse effects and limitations.
The primary limitation, which it shares with all IV hypnotics, is respiratory depression. RMZ can produce dose-related central respiratory depression and subsequent desaturation. The key clinical trap is the synergistic effect. Using it with opioids profoundly increases the incidence and severity of these reactions. You should always titrate opioids first for pain and then titrate RMZ for sedation and just maintain vigilance.
We stressed its superior stability, but we do have to acknowledge the potential for hypotension.
Yes. While it's far milder than propofol, RMZ is still a CNS depressant and a vasodilator. It will cause a transient decrease in arterial blood pressure from decreased systemic vascular resistance. The drop is mild, but the risk is certainly amplified in hypovolemic patients, the elderly, or when you give it with other strong depressants.
The major pharmacological limitation is the limited analgesia.
Cannot be overstated. RMZ is a pure hypnotic and sedative agent. It provides no clinically useful analgesic effect. This necessitates concurrent opioid administration for painful procedures, which forces the clinician into that careful balancing act against synergistic cardiorespiratory depression.
What about practical limitations that affect its adoption?
A critical practical limitation, which is common to all newer patented drugs, is cost and availability. RMZ is significantly more expensive than generic midazolam or propofol. And this financial barrier often restricts its use, particularly in cost-sensitive healthcare systems. It means its clinical superiority has to be really rigorously justified based on improved patient safety or efficiency gains like faster recovery room turnover.
Let's dedicate a section to that ultimate safety mechanism, the specific BZD antagonist flumazenil. What is its precise mechanism of action in this context?
Flumazenil is also an imidazobenzodiazepine derivative, which lets it fit perfectly into the receptor site. Its mechanism is that of a competitive antagonist. It binds with high affinity and specificity to the same benzodiazepine recognition site on the GABA-A receptor that RMZ occupies. By binding competitively, it blocks the effect of the agonist RMZ without activating the channel itself.
And when is flumazenil indicated for Remimazolam use?
Its indications include the routine reversal of RMZ sedation after a procedure to speed up recovery and discharge. That's often done just to guarantee a minimum recovery time. More critically, it's the immediate life-saving treatment for excessive sedation or respiratory depression resulting from an overdose of RMZ or any other BZD.
We've hinted at this, but could you elaborate on the clinical relevance, especially that massive reduction in the risk of resedation? That detail seems very high yield.
It is. The speed of reversal is remarkable. The onset is usually within 1 minute of injection. But the crucial advantage with RMZ is the negligible risk of resedation. With older, long-acting BZDs like diazepam flumazenil, which has a relatively short half-life itself, wears off long before the agonist is eliminated. This leads to the risk of the patient resedating hours later.
But not with Remimazolam.
Not with Remimazolam. Because RMZ's elimination half-life is ultra-short, only about 0.4 hours, and its metabolite is inactive, RMZ is cleared from the body faster than flumazenil's reversal effect wears off. This eliminates the source of clinical relapse, making RMZ reversal safer and much more predictable than reversing traditional long-acting BZDs.
What are the standard flumazenil dosing parameters we should know for the exam?
For general BZD reversal, the initial dose for partial antagonism is typically 0.1 to 0.2 milligrams IV over 30 seconds. You can repeat doses every minute as needed. For complete antagonism, you might escalate up to a maximum cumulative dose, which is generally restricted to 3 milligrams. For the RMZ scenario, knowing that 0.1 to 0.2 milligram initial dose and the 1-minute onset of action is probably sufficient.
Okay, now let's build that comparative matrix, which is so essential for a 20-mark essay. We'll create a dynamic comparison, item by item, focusing on what truly differentiates these agents.
Let's start with metabolism. RMZ uses tissue and plasma esterases, CES1, making it organ-independent.
Midazolam is hepatic CYP450, so it's hepatic-dependent and prone to drug interactions.
Right. And Propofol uses slower hepatic and extrahepatic clearance. The exam takeaway is that RMZ's organ-independent PK is its prime advantage, especially in patients with comorbidities.
Metabolites are next.
RMZ produces no active metabolites. CNS 7054 is negligible.
Midazolam produces that active metabolite, 1-hydroxymidazolam, which causes prolonged sedation and renal failure.
Exactly. And Propofol has none. The critical comparison there is midazolam versus RMZ in the context of renal failure.
Okay, the context-sensitive half-time dependence.
RMZ's CSHT is independent of infusion duration. This guarantees predictable recovery.
Midazolam's is short, but still time-dependent. It gets longer the longer you infuse it.
Correct. And Propofol's CSHT becomes very long with a prolonged infusion, leading to a delayed wake-up. RMZ offers the most predictable recovery for continuous infusions, hands down.
Hemodynamic stability, a crucial clinical choice point.
RMZ offers high stability, significantly less hypotension than Propofol. Midazolam also has high stability.
While Propofol has low stability, causing that pronounced hypotension.
The clear exam relevance. RMZ and midazolam are safer choices for unstable or volume-sensitive patients. Your ASA 3s and 4s.
What about respiratory effects and antagonist availability?
Respiratory depression is dose-dependent for all three. Propofol often has a narrower therapeutic window, a higher risk of apnea on induction. RMZ and midazolam are generally comparable. The antagonist is key, though.
Yes for Remimazolam and Midazolam, no for Propofol.
Exactly. Yes for flumazenol with both BZDs, no for Propofol, and that difference hugely enhances the safety profile of the BZDs.
Finally, let's compare the quality of sedative efficacy.
RMZ offers efficacy that's comparable to Propofol. It's highly effective and easily titratable, but it's definitively greater than midazolam. This balance of high efficacy with high stability is RMZ's unique contribution.
Okay, let's now focus on the conceptual knowledge that turns a good answer into a distinction-level answer. The common Viva traps. Start with the concept of the soft drug.
Right. The term soft drug is used for drugs that are intentionally engineered to have a built-in metabolic fault line. For RMZ, that's the Ester linkage. This design ensures the drug is rapidly and predictably metabolized by those ubiquitous, non-specific enzymes into completely inactive compounds.
So it's designed to be fragile in the body.
Exactly. The soft design guarantees an immediate and clean termination of the drug's effect when you stop it, independent of the variable, sometimes impaired, capacity of major organs. It's the hallmark of modern high-precision pharmacologic design.
We have to elaborate fully on the difference between ester metabolism and hepatic metabolism. The examiner will definitely challenge you on this core concept.
Let's break down the functional difference. RMZ, with its ester metabolism, ensures extremely high clearance, about 70 LH. This process is capacity independent and highly predictable across a huge patient population, largely unaffected by things like renal failure. The high clearance means that accumulation is structurally impossible.
And midazolam.
Midazolam, with its hepatic metabolism, relies on the CYP3A4 enzyme system, which is prone to saturation. Clearance is much slower, and it's highly sensitive to external variables. Enzyme inhibitors, like certain antifungals, can drastically slow its clearance, and we've already discussed how the active metabolite accumulates in renal failure. Your answer must stress that ester metabolism gives you reliability, while hepatic metabolism introduces variability and the risk of accumulation.
So if the examiner gives you a clinical scenario, say a 75-year-old dialysis patient for a long colonoscopy, and asks you to justify using RMZ over midazolam, what's the safest examiner-approved phrasing?
You have to prioritize the PK profile. The best phrasing focuses on guaranteed safety. Something like, I would choose Remimazolam because of its organ-independent metabolism by tissue esterases, which guarantees that the drug will be rapidly and predictably cleared, regardless of the patient's end-stage renal failure.
You mentioned the metabolite.
Furthermore, the inactive metabolite, CNS 7054, avoids the risk of accumulating the potent active metabolite 1-hydroxymidazolam that would inevitably occur with midazolam, preventing prolonged and potentially life-threatening post-procedure sedation.
Yes, very clear.
A strong summary statement to use in Aviva to connect all the concepts is, RMZ provides the hemodynamic stability and flumazenil's safety net of a benzodiazepine, combined with the ultra-short, predictable, context-insensitive kinetics we usually only see with remifentanil. That shows integrated conceptual mastery.
Even in an oral exam, the ability to mentally structure and visualize complex systems is key. Let's discuss how to prepare for the visual component of a pharmacology answer, specifically the GABA-A receptor schematic.
You should be ready to sketch the basic pentameric GABA-A receptor structure. Make sure you can draw the 5 subunits, typically consisting of alpha, beta, and gamma. The key to a good sketch is accurately marking the binding sites. GABA binds at the interface of the alpha and beta subunits. The crucial BZD binding site is specifically at the interface of the alpha and gamma subunits.
And how do we illustrate RMZ's action on that diagram?
You'd show RMZ binding to the BZD site, and then use an arrow or some enhancement to show that this binding increases the frequency with which the central chloride channel opens when GABA is present. This is the visual proof that it's a positive allosteric modulator, not a direct agonist.
We've emphasized comparison tables repeatedly. Why are they so critical for high marks in a long-form answer?
A well-constructed comparison table shows intellectual discipline, and it saves the examiner a lot of reading time. By isolating the key differences, metabolism, CSHT, active metabolites, hemodynamic stability between RMZ, Midazolam, and Propofol, you immediately highlight the most crucial concepts for the examiner. It's the fastest way to convey that you've mastered the material.
Finally, how should our listeners structure a complete 10 to 20 mark answer on newer drugs? This is really the blueprint for success.
Follow the standard logical pharmacological sequence. Start with a brief introduction and classification, move to chemistry, stressing the ester group, then mechanism of action covering GABA binding and subunit specificity. Then dedicate the majority of your space, maybe 50–60% of the content, to pharmacokinetics. That has to cover CES1, organ independence, the inactive metabolite, and CSHT.
Okay.
Follow that with pharmacodynamics, focusing on the CV and respiratory stability contrasts. And then conclude with clinical uses, a table of advantages and disadvantages, and a powerful summary paragraph. The examiner is checking that you understand the drug through the lens of its unique PK profile.
We've broken down Remimazolam from the ester bond up to the discharge note. Let's provide a final high-yield bullet point recap to lock in these non-negotiable facts.
Okay. 1. RMZ is an ester-based BZD cleared by carboxylesters 1. 2. Its metabolism is rapid, predictable, and organ-independent. 3. Its CSHT is independent of the duration of infusion. 4. It produces an inactive metabolite, avoiding accumulation risk. 5. It offers hemodynamic stability superior to Propofol. 6. Reversal is guaranteed to be fast and safe with flumazenil, with virtually no risk of resedation.
And let's distill those into 8 to 10 critical take-home exam points that will differentiate the expert candidate.
Remember these. First, define the soft drug concept. Second, explicitly contrast RMZ's inactive metabolite with Midazolam's active one. Third, justify its use in high-risk patients like ASA 3 and 4 and those with end-stage renal failure. Fourth, remember the primary sedative bolus dose range, 2.5 to 5.0 milligram.
Go on.
Fifth, know the reversal time with flumazenil, 1 minute. Sixth, understand its primary utility in daycare and procedural sedation. Seventh, state the important caveat. You need caution and a potential dose reduction in severe hepatic impairment. And eighth, always mention the crucial limitation, the absolute lack of useful analgesia.
Let's wrap this entire discussion with a model conclusion paragraph that summarizes all the technical and clinical excellence of the drug.
A model conclusion should sound assertive and integrated. Something like, in conclusion, Remimazolam represents a significant pharmacological advance by successfully combining the core safety profile of benzodiazepines, namely the preserved cardiovascular reflexes and the safety margin of flumazenil antagonism, with an ultra-short, highly predictable, and context-insensitive pharmacokinetic profile. Its organ-independent metabolism by ubiquitous tissue esterases and lack of active metabolites position it as a modern agent of choice for precise, titrated procedural sedation and short general anesthesia. This innovation specifically benefits high-risk patient populations, especially those with hepatic or renal dysfunction, effectively resolving the major pharmacokinetic shortcomings inherent in its predecessors, Midazolam and Propofol.
That brings us to the end of this very comprehensive deep dive. We've established that RMZ is chemically designed to solve the most persistent clinical problems we see with IV sedation: unpredictable recovery and organ dependency. But consider this final provocative thought for your own reflection and preparation. Propofol is highly accessible. It offers certain inherent antiemetic qualities and sometimes allows for opioid-sparing effects. RMZ is often more expensive and strictly requires supplemental analgesia. So consider the costs and the clinical trade-offs. Where specifically do you predict RMZ's clinical superiority? Its predictability and stability will make the financial investment absolutely non-negotiable in future practice. And where will Propofol's established role remain dominant? The future of anesthesia is in balancing pharmacology, cost, and patient outcome. Keep focusing on those key differentiating PK points. They will be the cornerstone of your examination success.